Everybody. So for those of you who don't know me, my name is John Granton, and I'm a physician at University Health Network, UHN. And Crystal, I don't know if you want to introduce yourself as well. There's our patient here who was one of my patients in the past, but has moved on to a normal life. So, yeah.
Yes, I had a double lung transplant November 18th, 2023.
So Crystal's the most important person in this talk. I'm going to talk a little bit. I'm going to talk more like I'm meeting you for the first time as my patient that I'm having a conversation with about transplant. We'll talk a little bit about what transplant is, why we transplant, and what the hopes are for transplant, and also, I guess, promote the Toronto program unabashedly because historically it's been a very innovative program and is the largest program worldwide by volume, and still represents, I think, a very innovative, creative program that's done amazing things over time. So I'm just going to talk a little bit about that as well and some of the innovations in transplantation. Okay, is that all right? And if I say something that you don't understand, it's because I didn't say it properly. So just much rather you raise your hand and make this a conversation rather than me just talking. So if I have my back to you, just yell at me, okay? All right. So I have received support mainly for our fellows through philanthropy and also through pharma, but it doesn't come to me directly. Actually, I don't take any fees any longer. Any fees I do get go to our foundation. So this is our new rep, but he's converted. It's this bumble's converted. He's going to make breathing great again. So yeah. So we're going to talk mostly about lung transplant. We don't usually do heart-lung transplant unless you have structural heart disease, like advanced congenital heart disease, complicated congenital heart disease. You have an atrial septal defect, we would repair that after transplant. Even if you have a ventricular septal defect, we may repair it at the time of surgery. So when I'm talking to you, it's mainly about lung transplant, and I would only be having a conversation about double lung transplant because putting a single lung in is not as good in somebody with pulmonary hypertension than putting two in. And we've been trying to advocate for this, much like you advocate for your underlying condition of pulmonary hypertension. We advocate for transplant as an option for patients with advanced lung disease. And we've been pressuring and pushing and trying to raise awareness that these conversations should occur early on in the patient's journey so that they understand essentially what could be their future, and so that they can make appropriate decisions in forming their family, planning their lives, making decisions if that came to bear. And also so they don't hear it at the first time if things start to go wrong when you're being overwhelmed with all the other stuff. At least it's in the back of your head as a possibility. And we recognize that the timing of that is difficult, but certainly at least have a discussion about the option of transplant maybe being in your future. Not something we're considering now, but because we're starting all these medical treatments, but it's something for some people which is the only option because there are no medical options. And so we're promoting that happen early on. And then if things aren't going well as planned, or in our own program, if you're starting intravenous or under the skin therapies, parenteral therapies with infusion pumps, we often just start that conversation with the transplant program. You would see me or somebody like me in the transplant program to have a conversation about what transplant's like, why we transplant, the outcomes from transplant. So that's kind of what we're going to do today. So this is the referral to transplant and a discussion. And why also do that? Well, the other reason is because sometimes you have to prepare physically for transplant. So if you're overweight, you have to lose weight because there's a clear association between size and outcomes. We won't transplant people who have a BMI over 34. Somebody who's actively smoking or using other non-prescription medications for fun, we need to assist with that and get them to stop smoking. So you can't do that if you only have a month to be listed. So you have to start that much early in the journey, start those discussions about improving weight, improving fitness, getting active physio, getting some rehabilitation, so you can look like the Homer on the right. Does this happen very often? This was a PHA registry in the US. You don't have to look through all that, but basically they asked the question, well, how many people were actually referred for transplantation through this? And you can see that in general, a lot of people were never referred. The majority of patients were never referred for transplant. They tended to be balanced. They tended, interestingly, there wasn't a lot of discrepancy, but they tended to be higher education. Quite surprisingly, at least for me, they were often the visible minorities, which were more often referred compared to people who were non-Hispanic white, which is kind of strange from the United States in general, I would say. But also, if you look at the type of conditions, the number of people who were referred is very low, irrespective of whether they were using things like methamphetamines, if they had an underlying connective tissue disease like scleroderma, if they had HIV, a very small percent of patients who could have benefited from transplant, or at least a transplant conversation, were ever referred for that discussion. And more shockingly, even people who had very advanced disease, only less than about 20% of them, at most about 25 or so percent, were referred for transplant assessment. Now, that doesn't mean maybe they didn't want, weren't eligible, but it's a small percentage. So we want to fix that. And as a result, this is the World Symposium that I was part of. And you can see if you look at high risk up there, it references F, and F is down there, transplant referral. Well, that's about as good as we could do. So if you come in really sick, we will have a conversation with you early on in your journey. If you come in not too bad and you do well, we won't necessarily have that conversation initially. If you have a high risk associated condition, if you have advanced lung disease like emphysema or pulmonary fibrosis and pulmonary hypertension, we know there aren't many medications to treat that, so we have that conversation earlier on. As I was advertising, Toronto has a rich history. You can look kind of through here in the 1900s. There was some early experimental transplantation. Alexis Carrel, who's at the top left, was awarded the Nobel Prize for discovering kind of why tissues are rejected. And then the first human lung transplant wasn't with our program, it was in the States at the University of Mississippi, survived a short period of time. And that was really because there wasn't something called cyclosporin, which was now kind of allowed for the immune system to avoid attacking the transplanted organs. For successful heart-lung transplant was in Stanford, and the royal we, Joel Cooper was the surgeon at the time, did the first long-term single and the long-term double lung transplant in 1983 and 1986. And I was very young at that time. If you look at the total number of transplants, since 1983 to now, we've done 3,411 transplants. First ever, 96% retransplants, you can see, is very uncommon. Particularly getting a third transplant is very uncommon. So the thing I would say to patients is they always ask, well, what if my lungs fail? Would I be eligible for another transplant? And the answer is generally no, for a lot of reasons. But that's something you should count on. But in the occasional instance, we actually provide that. If the graft fails early and you're not too sick, and you tick all the boxes, and you want to go through this again, then we would potentially offer it. For you, just so you know, you can see heart lung is very uncommon. Single lung in green is less common, not for pulmonary hypertension in general. Most of the time we do bilateral, 2 lungs, and that's what you would be offered. And if you look at the number of listings by type, you can see that we do over 200 per year, and you can see the majority of them are double lung transplant versus single lung transplant, and very rarely heart lung transplant. And you can see that kids are transplanted much less commonly than adults. The indications of transplant, the thing to watch here is the disappearance of the pink. And this is what we'd like to see happen to pulmonary hypertension. We call it primary pulmonary hypertension just because that's what we used to call it. But you can see the pink thing disappearing, and that's cystic fibrosis. That's basically disappeared. I can't remember the last time we transplanted somebody with cystic fibrosis, which is amazing. And that's because of new therapies based on understanding of the disease and targeted treatments, which is incredible. Maybe, well, that's the aspiration, is that we never have to send somebody ever again for any form of transplant. Not there yet. Pediatric transplants. Again, cystic fibrosis was the biggest one, and you don't see a lot of pulmonary arterial hypertension. You don't even see a lot of pulmonary arterial hypertension here relative. It's a small percentage of the total. So if you look at the red, it's a very small number of people we transplant with pulmonary hypertension, just because it's a less common condition than other forms of diseases. That's true for kids. And you can see the cystic fibrosis has also disappeared in children, which is amazing. I'm going to skip through this. Oh, maybe not. So if you look at our volumes, lung transplants, you can see it's quite high. But on the bottom is the number of deceased donors that we have access to. And you can see that even though the number of people who die and consent to donate, or their families consent to donate, is being relatively flat, we've been able to increase the number of transplants, which I think reflects the innovation. Why is that happening? Well, when I was training, we never took people who, for lungs who were over the age of 60, were smokers. We're taking lungs that otherwise we may have discarded. And the way we're able to do that is this thing, which is extravascular lung perfusion, which was invented in Toronto and was published in the New England Journal of Medicine. Marcelo Seipel and Shafka Shabji were the kind of innovators here with a lot of people behind them. But basically, this is the two lungs, which are now being perfused and ventilated. And previous lungs, which you didn't want to take a risk on transplanting into somebody, would go on this system, and you could evaluate them to see what are they like over a few hours? Do they perform well? Can we fix them? Can we wash them out? Can we evaluate them? Can we test them? Can we dry them out if they're wet? And this is what this allows to do. Maybe it's going to allow us to do gene therapy. We're going to be able to, I'll show you, I'll mention it now, we can actually take the blood type away from this organ. Type A, we can put a detergent in it, strip it off, and make those lungs available to any recipient, which is totally cool. And if you look at the effects of this, the outcomes are the same. The yellow and green lines are indications of survival over time or behavior of the individual with the graft over time. And you can see there's no difference. They're as good as the other lungs, which is good because often you would worry about them and now you don't have to worry about them anymore. And if you look at the number of transplants, we're doing more and more off EVLP, which means for a few hours, they sit there, you evaluate them, and then you can transplant them. And it's become a bit of an industry. And the reason for that is because it also allows us to wait. And this is the board on a busy day, June 11th, 2015, pre-pandemic. And you can see there's a whole bunch of transplants ongoing. There's like 3 double lung transplants on the go. There's a couple of livers, kidneys, and everything like that. And previously, the OR could not have done this. We would have had to cancel 2/3 of those surgeries. And now, because you can put them on EVLP, you can wait and you can juggle the teams. And now, instead of doing transplants at 2 in the morning with a tired surgeon and tired team, or maybe a non-expert team, you can now wait till the morning to do these surgeries. So improved quality of life for the teams and also improved outcomes for patients because it's been shown you have a rested team, you have better outcomes. We're also a net importer, and this is information from our program. And what the lines show, or the summary of this slide, is that we actually take lungs from the United States as well. Generally, it's not first offered to us. They've gone through several offers, but they can't just sit there. The lungs can't sit and wait for somebody to decide to take them. So usually after the 5th or 6th time, we'll get a phone call, say, do you want these lungs? And they'll come to us, which is nice. And the outcomes from those, even though they're shipped further away, are the same. The other thing we're able to do, and this is sad, but it's taking advantage of a sad situation. And we recognize that in North America, fentanyl and fentanyl-related deaths and fentanyl-related brain death, because the person had an arrest, stopped breathing, and had irreversible brain injury and met the criteria for brain death, could be donors, except they often have coexisting hepatitis C infection. And you can't put an infected lung potentially into another person, they get hepatitis C. But what you can do on this ex vivo system, which is over here, you can see the lung in the box. You can shine light on the lung perfusate, the stuff that's going in and out of the lung, and actually kills the hepatitis C virus. And hepatitis C doesn't live in the lung; it floats in the bloodstream. So you can remove most of the hepatitis C virus and treat the patient, because we now have a treatment for hepatitis C. So if they become active, you can then treat them. So the burden of virus is almost zero. And even if they do acquire the virus, because it's fairly infectious, you can treat it. And so you can now use these lungs. And the outcomes for these patients are equivalent. So that's why we're starting to see more and more lungs. And this is the system. You can see the video there. You can see the little light thing there, ultraviolet, which is killing the hepatitis C virus. It's just very cool. We can also store them longer using creative methods. And we're now looking at successful 3-day perfusion. So you can keep these lungs on a circuit for 3 days and use them over 3 days. Just think of the opportunity and being able to ship lungs from further abroad, or being able to time transplant over for people. You don't have to live in Toronto anymore. You could live in Northern Ontario and come get your lungs. Be an elective procedure. Totally cool. I alluded to this. We can actually strip. Normally, we allocate lungs by blood type. So if you're type, A, you would get an A lung and that kind of stuff. Here, particularly an O recipient, you can see blood type A donor. You can't go into a B or an O because you have antibodies to the A. So you can only go into an A or AB. But if we strip off the A from the lung, it then can go into everybody. And the beauty of that is O is very common. But it's sometimes hard because although you're a universal donor, you're not a universal recipient. So O's are kind of disadvantaged a little bit. So this opens the opportunity for a lot of people on the waiting list as well. Okay, so the hard part, are we doing okay time-wise? Okay, all right. The hard part is discussing survival, always with people. And I know living is one thing, but living well is probably the most important thing. So my conversation with people is, I can't predict if you're going to live for how long with your condition or after transplant, but I can tell you in general, you're going to live better, which is you're going to tell that story. But I'm going to tell you the concern about transplant and people with pulmonary hypertension is that if you look at that little blue line there, this is the survival over time in years. Our average survival after transplant is about 7.7 years. People with pulmonary hypertension tend to die earlier after transplant. Technical issues, blood pressure issues, a whole bunch of early injury issues, and they've got this little downslope. But we've been able to almost eliminate that in many of the big programs now, which is nice. Because if you survive after the first 3 months, you actually do better than most other people who get a transplant or who are transplanted. Some people with emphysema, COPD, they're often older. You do almost as well as cystic fibrosis patients, which we don't transplant anymore. So now the pulmonary hypertension people have the best long-term outcomes because they're often younger. They don't have a lot of other associated conditions that can complicate transplant. Now, you may say, geez, I don't want to take the risk of that, but I'll show you the survival lines for people with green, low risk, red, high risk features of pulmonary hypertension, which is much shorter than your chances of dying after transplant. So that's the decision. You have to I don't know if you remember that old commercial, the insurance commercial, where you have the jockey jumping from one horse to another. That's kind of what you have to do. You're betting on which horse is going to take you across the finish line. You don't want to jump too soon, but you also don't want to jump too late because that horse is not going to be there for you. So timing becomes really important. But a discussion about your quality of life, if it's really impacting and you're feeling lousy because of the medication or because of the disease, that's when you had to start thinking about transplant, because your life in general will be better after transplant than before transplant. Okay, I am going to whip through this. So this is what we're trying to do in the Toronto program. We're trying to create this system where we have more organs. I would encourage you to reach out to your family, everybody you know, and not only promote pulmonary hypertension, but also promote becoming organ donors. I hope everybody in your family has signed their organ donation card or done it online. And more importantly than just sign it secretly in the closet or in your bedroom all by yourself. That's more an attempt to have a conversation with your family, make it very clear that you want your organs damaged. We are donated. I speak to high school kids all the time, and we go to these schools discussing the promoting transplant, and kids are appalled that their parents can veto their decision to transplant their organs. So listen to your kids. Empower them to make the decision to also become organ donors, because sadly that does happen. So raise the conversation, not only about pulmonary hypertension, but also the importance of donation. So with that, I'm going to pause here, and I think thank all my teammates who do amazing things. And I think the most important conversation is listening to Crystal and her journey and her experiences and in her words. Good. Yep.
Hello. Can you hear me okay? That sounds okay? Excellent. Okay. So I'm going to probably read this through. It talks about my journey from right at the very beginning when I was first diagnosed, and then right through to what it was like going through the transplant, and then what life has looked like now. So when it all began, I was at my yearly physical in January of 2023, where I explained I was having shortness of breath walking up the stairs and feeling more tired than usual. This started a series of tests with a cardiologist who said my heart was fine, but there was something wrong with my lungs. I had never thought that my lungs were going to be the problem. I was referred to the Firestone Clinic in Hamilton and saw Dr. Hambley, and this started a process of tests to figure out what was wrong. I knew something was going on, and my worst fear was becoming a reality. So I need to share a little background about this because it's kind of relevant to my story. 27 years ago, my brother was diagnosed with a rare form of pulmonary hypertension called pulmonary capillary hemangiomatosis. This is a very rare and progressive disease. His only option would have been a heart and double lung transplant. However, his health deteriorated very, very quickly, and he died 2 months from diagnosis. So my brother's doctor at the time was actually Dr. Granton. And then while I was in ICU, following my transplant, I also did see Dr. Granton as well. So talk about a full circle of care that no family wants to experience, but we did. So given my family history, genetic testing was completed for myself and my parents. We found out that both my parents carry the gene associated with this disease that was passed to both my brother and myself. So in June of 2023, I was diagnosed as well with pulmonary capillary hemangiomatosis. And to say the least, I was very fearful and overwhelmed regarding my future. It was very quick for my brother, so it was really scary to think, what was my outcome going to look like? Transplant was my only option. More tests and procedures were completed to see if I was a candidate, and thank goodness I was. After signing consents, completing paperwork, and given a 170-page transplant manual, I was officially listed as level 2 for a double lung transplant on September 28th, 2023. I continued to do my physio and function the best I could while I waited. My heart continued to deteriorate rapidly. I spent 10 days in hospital in Hamilton, and I was suffering from right heart failure. I needed a miracle, and soon. November 17th, my status changed to level 3, and within 3 hours, I received a call for a potential match. We arrived at the hospital by 10 p.m., and I received my double lung transplant the following day on November 18th, 2023. I was in surgery for over 8 hours. I'm forever grateful to my donor and their family for giving me the chance to live again. So receiving that call, I was filled with many emotions: fear, worry, will this even work? Is this something that's going to help me? Will I survive the surgery? There was also excitement, a chance to live and a chance to breathe again. And there was also sadness, thinking that here my life is going to change, and it's also changed for my donor's family as well. Despite having the manual, it's really hard to imagine what your journey will be like following a transplant. Some people recover very quickly, while others, like myself, had some setbacks. I was 17 days before being removed from the ventilator. I was not ready to breathe on my own, I guess. In hindsight, as hard as that was for my family to watch, I really do believe that I was healing and I was giving my new lungs time to adjust and to fight off some infections and things that were happening. I had a trach until December 19th. December 23rd, I passed my swallow test and had my first drink and meal, which consisted of, my dad did records of everything through my journey, consisted of soup, meatloaf, potatoes, apple juice, and jelly. So that was my first meal from the 17th of November. I was fed food, just through a tube. And then on December 28th, my feeding tube was removed. Then December 30th, I had a massive pulmonary embolism. It was provoked from the surgery. The blood clot traveled from my leg into my lung and was sandwiched between my heart and lungs. I was back in the ICU, had the ventilator again, the feeding tube again, and underwent a procedure through the groin to remove the clot. I was actually the first person who'd had this procedure done before on someone who'd had transplanted lungs. So I'm in a journal. Woo! Not something you want to be in a journal for, but again, no, you don't want to inspire for it. Delirium and anxiety. There's a little section in the manual talking about that, and it doesn't prepare you for what that looks like. I had many, many vivid experiences that sort of only happened in my mind. And my family felt as if I was sort of just in another world. And a lot of the time when they would come to visit me, I would be staring at the clock for hours and hours, just sort of not present, not here. And having psychiatry as part of that team following surgery is really important because it did help to helped with my symptoms, and it also helped to explain that this is temporary. And what was interesting is that after the embolism, the delirium actually cleared. So I was kind of back to the normal old Crystal to some extent. So that was good. I also had radial neuropathy from the surgery. So the way they do the incision, it's a clamshell, so it goes across and they open you like this, and your arms are above your head for the surgery. And so it assumed that the nerve was constricted from being above my head. And so I had no ability to move my left hand. I couldn't move my wrist. I couldn't move my fingers. I couldn't lift it up. So it was, again, trying to learn how to do everything with one hand. I still, as you can see, I can move it now. So that was a pretty special day in the hospital. And I said to my parents, look, and both hands could go up. Like just even that movement I couldn't do. So just even that to start with was amazing. I still do have some tingling, but other than that, everything is fine. And it's just amazing how the body heals. Also, with the heart kind of being that muscle, over time, my right heart failure disappeared. So that's no longer any issue that I have right now too. So after being in hospital bed for so long, I had to learn the basics all over again. I had to learn to walk, use the stairs, and operate only with one functioning arm, one functioning hand. That lasted for a good 8 months with my hand. I was discharged from Toronto General Hospital and was sent to Toronto Rehab on January 12th. I worked very hard on my recovery, and within 2 weeks, I was discharged. My daughter Sophie was so excited for me to be coming home. I wanted to be home for my birthday on January 29th. I was discharged January 27th, and so I was in hospital for a total of 71 days. When home, I needed a lot of assistance with mobility, day-to-day activities, and my injection medication. I continued with rehab and multiple visits back to Toronto. I also had significant back pain, And with support of the team, that went away as well. I contracted a virus from the lungs called CMV, and it is pretty common. And so I've been dealing with some of those reoccurrences throughout the time with medication, and it's been okay as well. I've also had other blood clots in my legs since the surgery, and I continue to be on blood thinners, and that's okay. I'm okay with that. Also, due to the medication, I do have steroid-induced diabetes, and I have an acute kidney injury that's monitored by my team. I'm now immune compromised and will take anti-rejection medications for the rest of my life. And again, that's okay. I'm here today and I'm alive. I never questioned the decision to have a transplant. I wanted to live and I wanted to breathe. Is it scary? Absolutely. Were there days that I felt I would never get better after surgery? Absolutely. Is it worth the setbacks and recovery? Absolutely. My support system was key to making it through my surgery and recovery. My family held me up when I couldn't stand, and they loved me through every scar, every setback, and every single terrifying moment. I'm now coming up on my 2-year lung anniversary in November, and I feel amazing. I have traveled to the Dominican Republic and Alberta post-transplant. I love to travel, and so that was really important to try to be able to do that again. I'm living each day to the fullest, and I'm grateful for each breath. So thank you for giving me the opportunity to share my story with you.
That's it.
Questions? Comments?
That's a great, I should just tape you and play it for people rather than me talking. And when I explain what a transplant's all about, it's actually a good idea to do that. You mentioned a lot of the things that you're experiencing now. Did you have any sense of any of that? Despite, we do all these things to help people understand what they're getting into. Do you think that helped you in any way, or is there a way we could do that better?
No, I think it's important to get all of that information and to hear it. Again, you're sort of, I knew that was my only option. So I didn't have time to think about other things either. And maybe that was good or bad, I'm not sure. But I knew I wanted to live, and I wasn't going to be able to. And I was very, very sick at the end, and it needed to happen as soon as it did. So I think, yes, it's important. All that information is great. The manual is great. You just don't think that all of that stuff potentially will happen to you. And I know there's some people that don't have very much happen at all. So that's where it's different for everyone.
Question down. Oh, maybe I don't know. Robin, do you want me to give you a microphone? There. Oh, that's
Go here.
So my question is there a possibility for lung transplant for lupus patients?
for lupus patients?
Yeah, who have severe compromised immunity.
Yeah, we've had to think, but yeah, it's possible to transplant people with on treatment for autoimmune conditions. You just hope whatever it is doesn't come back if you have an underlying condition. That's true for anything that causes damage to the body. You have to make sure that it's not injuring the kidneys. You alluded to the fact that your kidneys been injured, but if you come in already with kidney problems, you're much more likely to have kidney injury after the transplant, which might require dialysis, which we talk about all the time. And you've also probably been on therapy for your immune system, so you may have an element of diabetes, which you alluded to as well. So a lot of it just adds to the complexity and the chances of having other things happen, which sometimes are predictable, like the CMV, because we know that happens, but pulmonary embolism, I have to say, rarely see. And it's not something we probably even profile when we're talking to people about transplant. There are things that are unseen. And so it does increase the risk of unseen complications or unknown complications potentially. But we transplant people with a lot of underlying conditions that people get kidney transplants who have lupus, people get liver transplants for people who have autoimmune conditions, and we do transplant lungs for people who have autoimmune conditions. Yeah. And just a caveat, whatever I say up here that can never apply to you as an individual. I always speak in generalities. So
Thank you.
I'm going to kind of alternate between online and then I'll come to you, Jane. Okay. There's a question online from Angel. And I'm just walking back to the computer here. Okay. Someone in a rural community, you mentioned that EVLP prolongs the viability of the organ. Does this mean that patients no longer need to move to another city while awaiting transplant, thus not disrupting their life?
In general, that is true, but you still have to get here within a reasonable length of time. So there are limits, but certainly the boundaries have increased. But we also recognize that even if you lived here, to come to downtown Toronto would take you an hour. So unfortunately, 2 hours. Yeah. Yeah. So traffic's influenced this a fair bit. But in general, if you can get in, I forget what our catchment is now, but we have people living in different cities where previously we never would have accepted that they live in their cities in their homes with their families. Everybody would have to move to downtown Toronto, or the Toronto GTA, which had a huge impact on their lives, disrupted their families, had a huge economic impact as well. So it's better than it was.
Okay, hand over to Jane.
Thank you. I'm just wondering about my advanced age of 70 plus scleroderma. Is that is possibly a no for a lung transplant?
So again, I can't make any specific, but in general, we judge people by the totality of everything that's going on in their lives. So it's often not a one thing that's going on. And often if we start scratching below the surface, as we start to put you through your test before transplant, we start to discover things that would make us not want to transplant. So we don't have necessarily, we're not ageist. We aren't anti-scleroderma. We actually are one of the few programs that transplant scleroderma patients, but scleroderma patients have other risks for the transplanted organ that we would have to evaluate as well. So again, Jane, not specific to you, but in the generalities, it's always the totality of the person. And the biggest benefit is a strong family. So, we really do kick the tires on your social circumstances and your support network to make sure it's robust enough to withstand the stress of transplant. And maybe I'd be interested to hear how that affected your family a little bit. Are you okay talking about them?
Yeah, it was a lot. My parents, so I was 41 when I had the transplant, and my parents and my husband were down every day at the hospital. And my parents are both retired, so they were able to do that. But it was a lot. And Sophie was coming too. She just pointed at herself. She was there as well. And it was grueling. I mean, it's a lot and a lot to kind of see me there. And I wasn't communicating for a very long time until after the trach was removed anyway. And I was uncomfortable, and my parents would take me around in the wheelchair, and I just wanted to feel the breeze from going around. We did lots of steps. Well, I didn't. They did. They did lots of steps, kind of moving me around in the hospital. So the support system is definitely key, and that's why I know it's sometimes hard. And you see people talk about I don't have a person. You need a person. You need people to take you to appointments, especially after too. I can't drive after a transplant, so all of those appointments post. It's a huge not burden in a way, but also like something they want to do and to be there to support too.
we certainly recognize in critical care, one of my colleagues, Margaret Herridge, done a lot of work in recovery after ICU, and the lungs work fine, but it's everything else that takes a long time to recover. And we also recognize that the families have huge stress, financial stress, interpersonal stress, almost post-traumatic stress disorder, and require a lot of support as well, psychological support, psychiatric support, social support. So it really takes a village, but you actually have to try to heal the village too. So, yeah.
Speaking of support, I'm aware of a Toronto General Hospital lung transplant support group on Facebook, but are there other like virtual or other support groups for people in the pre-transplant and post-transplant stage that people can connect with?
Yeah, there are support. Often it's the important group are the groups, I would say, very disease specific. Often there's support groups that people lean on initially, and then you become kind of unique in that you're now a transplant wait person. So you're on a wait list or you're associated with that group. And then there are, I would say, less common support network for the post-transplant phase. I don't know, you can comment on your experience, but I would say most of it deals with the pre-transplant and the waiting, because it's very social. You're always coming in for your visits, you're interacting, they'd have a patient meeting before they go for their physio and other things. So, but post less.
Yeah, I would say less so for post, but I'm still on the Toronto transplant one, and there's lots of people that are on their post or post transplant. And it's nice to see sort of, how well they've done. And, people will say I'm 20 years or I'm 10 years. And those are great things to see. Those are things we all want to see, is those numbers. And we hope that that's going to be us as well. There's other groups too, that there's then transplant survivor groups that I'm part of, that are there. Sometimes you just, again, with anything with social media, is you have to filter out, and it doesn't always relate to you. But it is nice to see, especially now for me, to see those stories of, oh, I'm this and I'm going down to my follow-up visit 10 years or whatever it is plus. So those are the nice things to see.
Are there in-person ones or like Zoom meetings that you're aware of? Like I hear about transplant games where people gather and do that. But
Yeah, there's that. And right now there's actually the transplant trot that's on, and we're competing against all around Canada. And so my family's part of the Ontario team. So we're trying to reach 20,000 kilometers per province and raising funds as well. So there's lots of things. And then there's the Olympics, the transplant Olympics too, which we'll see. Maybe that'll be something I'll do too.
and where do you find all that stuff? Like where there's resources for support? Is there a website or?
No, I think a lot of that, like I would see that show up under that Toronto transplant Facebook group, things would show up. And then also the Toronto Civitan Club, they send out a newsletter. So that's where a lot of stuff comes up too, where they'll share about different things that are happening. I think that's where I heard about the trot, through that.
Thank you.
You're welcome.